November 11th, 2025. And today we're going to talk about goals and work. As always, we have our disclosures. Eduardo and I have presented these as many times in the past, and they haven't changed ostensibly. Ground rules, as always, this is a recorded session. Please keep your microphone muted unless you want to ask a question. You can also put in a question in the chat. We'll be looking at that. I may call on the audience if nobody is participating, just to stimulate some conversation. And of course, the chat function is always there. Respiratory therapy gets CRCEs, and there are CMEs at the end of this course. And we'll give you some QR codes to get to that at the end. Okay, as always, we start off with a little bit of SEVA background knowledge. And just to remember, a ventilator is designed to be an automatic device that provides some portion of the work of breathing. Now, the problem is whether it does that properly or not depends on the mode of ventilation and the interaction with the patient. And this is a slide that we show many times. It shows the relationship between the work output by the ventilator versus the work output by the patient. So in modes that are volume targeted, that is volume control, pressure control with adaptive targeting, then we see that as the patient's effort increases, they do more work and the ventilator puts out less work. Now, how do we know that that's happening? Well, it's because, again, from the equation of motion, we see that P vent plus P mus equals elastance times volume plus resistance times flow. So in these volume targeted modes, the right-hand side of the equation remains constant. So if that remains constant, as P mus goes up, P vent has got to go down. So we see distortions in the pressure waveform. And because work is a function of pressure and volume, if the pressure goes down and the volume stays the same, then the work goes down. I hope that makes sense anyway. Any questions on that? Okay, so that's volume targeted modes. What happens in pressure targeted modes? Well, in regular pressure control or pressure support with set point targeting, as the patient makes a high inspiratory effort, then the ventilator waveform doesn't change. Why? Because it's preset. That's what pressure control means. So the only thing that happens is that the patient gets a higher tidal volume, but the ventilator P vent does not go down. That means the ventilator work per breath remains relatively constant. So there's less work shifting from the ventilator onto the patient. So you might ask, well, is there any other possibility? Well, there is one. And that is this situation, where we have modes with servo targeting, whereby as the patient's inspiratory effort goes up, the work output by the ventilator goes up to match it. In other words, it's basically these modes are amplifying P mus, or they're assisting P mus in proportional to how much work the patient does. And that's, again, the servo targeting scheme with pressure control. And the typical modes we talk about here are proportional assist ventilation and neurally adjusted ventilatory assist. Okay, so let's move on to our cases. Here's the first one. We see that this is a servo I in this case. We see the mode is PRVC. And as always, we ask you to give us the tag. What do you think the tag is for this?
No answers yet.
In the chat, Sherry?
No answers yet. Oh, here we go.
Oh, there we got a PCCMV. So there's no targeting scheme on that. So you got to pick a letter for the targeting scheme. Makes a big difference, right? So remember, S is set point, R is servo, A is adaptive. Those are the ones that we most often want. There we go. Karsten says A,
yep.
Fernando says A. There we go. Everybody's on board now. This is great. So again, this is pressure control, CMVA. So how do we know it's pressure control? Anybody want to offer a guess? Look at the flow. Yes. Flow for a passive patient anyways would have an exponential decay like this. So you have a high peak flow, it exponentially decays, and pressure we would expect to look something like that. Now, certainly the pressure waveform is distorted, and we're going to get that in a minute, but it's pressure control because we don't have a geometric form for the flow. It's not square, it's not rectangular, it's not a triangle, it's this thing. Okay, so how do we know that this is continuous mandatory ventilation? You're telling me that every one of these breaths is mandatory. How do you know? Anybody? Guess we should start off by reviewing what's the definition of a mandatory breath. Yes, that's the answer. Patient triggered and patient cycled, and I think it was Megan said, yes, we see that inspiratory time is constant, and we know that because we have this little period of zero flow. Inspiratory time is constant. The only way that could happen is if you preset it, and if you preset the inspiratory time, that means every breath is time cycled, and that gives you the definition of mandatory breath. Excellent, very good. Okay, and as far as the adaptive targeting, we can't tell directly from here for a variety of reasons, but we find this out because we know it's PRVC, and we can just look it up in the ventilator mode map application, and it tells us. And after we've done this a million times, we remember it though. Okay, so let's move on to the load. Look at inspiration. Inspiration is the period of positive flow, flow above baseline. What's the main load we're seeing here? What do you think? This is pretty obvious, I think. So you've already said it, you know. Yep, PMUS, PMUS. We see that PMUS is distorting the flow waveform, but it's really distorting the pressure waveform. So let's call this PMUS on inspiration. And when you have this much PMUS, it really masks any effect of the elastic and resistive load. So in order to tell if this patient has a high elastic or resistive load, we're going to have to look over to expiration, right? The expiratory time is all the period of negative flow to the time of positive flow. All of that is the expiratory time. Now, do we see any evidence of PMUS there in the expiratory time, like we did in the inspiratory time? Yes or no? As Eduardo says, have no fear. There we go. No PMUS. There's no real distortion of the flow waveform. In fact, it looks identical. It looks like we have passive exhalation for all three of these guys. But then that leaves us to assess, are we talking about a resistive load or an elastic load? And again, the way we tell is you look at the expiratory flow curve. It is exponential, which is pretty nice, but it does have a long or a short time constant. What do you think? Long or short? In fact, there you go. So we have one long and one short. So how do we know? Well, the period between these lines is 1 second. So we're going from peak flow to zero flow in like 3/4 of a second. So if the normal resistance is 10, and the normal compliance is like 50, then the normal time constant is about half a second. So you shouldn't be able to get to zero in less than a minute and a second and a half. So this is a short, there you go, Fernando gets it. A short time constant tells us that we have low compliance or high elastance. If we had a long time constant, it would look something like that. And that would lead us to believe that there was a large resistance, which we do not see here. Very good. So going on to inspiration, would you gauge this or would you judge this as being normal assistance, over assistance, or under assistance based on everything we've just said? And this relates again to our very first slide. So remember that we said that this is adaptive targeting, which means that we have a volume target. You set a tidal volume target down here. So in that sense, it's the same as volume control, but it's pressure control with a volume target. But it's the same in the sense that, there you go, we have an under assistance because as the patient's P mus goes up, the P vent goes down. If the P vent goes down, that means, and the tidal volume stays the same or goes higher, then that means the work per breath goes down. So the patient is not getting assistance. And in fact, if we look at where PEEP is here, yeah, large amount of under assistance. In fact, this is what some people could rightly call flow starvation because we're not giving the patient as much flow as necessary to keep the pressure at the PEEP level. So this is severe work shifting. Very good. Now, what about cycling? Let's move on to cycling. Our choices here, is this a normal cycling? Is this an early cycling or a late cycling? And in this case, it's pretty clear what's happening. Normal cycling. We have a normal cycling. Do we have anybody who wants to disagree with this? So a normal cycling would imply that after P mus ends, which is about here, that the ventilator lets the patient exhale. Is that what's happening here? Anybody else? I think somebody said something in the chat. I didn't see it. Anyone want to disagree
late
that
cycle.
this is not normal? Excuse me?
It's a late cycle.
Late cycling, yeah. So the P mus turns off, and then after some few milliseconds, the ventilator turns off. So that's the definition of late cycling. And again, you can tell because you assess the effect of P mus. You kind of go in your mind's eye, what is the duration of P mus? Something like that. P mus shuts off. Then the ventilator says, I'm not letting you exhale until now. And now you get to exhale. So that is a late cycle. So moving on to expiration. Do we see any evidence of an expiratory work, or would you call this a normal expiration? And we all pretty much already touched on this, but anybody want to say it out loud? Is this normal or expiratory work? By expiratory work, we typically mean the patient is trying to exhale forcefully, right? So we said that this is a normal expiration. Yep, that's a normal expiration because expiratory work would make the flow go away from baseline like that, right? That would be expiratory work, which we are not seeing. So there we go. We have We have during the load is expiratory elastance, a short time constant. We have a normal trigger. We have under assistance. We have a late cycle and a normal expiration. So you've just made all this assessment at the bedside. And what would you do about it? So what's the first question we ask when we say try to make a decision of what to do? What to do always begins with an assessment of what? The goal. There we go. Can we reach a consensus on what might be the goal for this patient? What do you think? This patient's on 60%. Relatively comfort or liberation. Patient is pretty much in CPAP. Yeah, he's in CPAP, but not because that's what we want, is it? Is our goal for this patient CPAP when they're in PRVC and they have a lot of work shifting? Safety. Carson says safety. So now we have one of each. Safety, we have comfort, and we have liberation. So would you liberate somebody who's doing this much work and on 60% oxygen? Now, I will admit I haven't ventilated a patient for a while, but I don't think I would do that. Trish says no. Okay. So it's down to safety or comfort. And I would argue that a patient doing this much work, I'd be concerned about their safety, right? You can have damage to the diaphragm. You could have, you can induce pulmonary edema. We could certainly have the patient being uncomfortable, but I would say probably safety is our first goal and comfort might be secondary, just depending on the other clinical situations. So Ariel says switch to set point CMV mode or sedate. There you go. So set point, as we saw in the very first slide, would keep the pressure constant. So there wouldn't be as much work shifting. That's true. And then it just comes down to how much tidal volume does the patient get in set point. If the tidal volume goes over our safety limit, if the dosage goes above 8 mLs per kilogram, then we're back into a safety concern. So again, if the goal is safety, the very first thing you'd ask yourself in a patient like this is, why are they doing this clinically? Are they hypoxic? Are they anxious? Are they in pain? We try to address that. If we can address that, we do it. We might go to a different mode to see if we can reduce the work shifting. And if none of that works, then we're probably going to have to sedate and paralyze, because no mode of ventilation can make the patient stop doing this if there's a good reason that they're doing it and we can't address it. Okay, so that's a pretty good analysis of that patient. So we switch over to another situation. And again, we're going to have to speed up a little bit. What's the tag for this? Pressure support CPAP. This should be pretty simple. Everybody should know this off the top of their head. There you go. Pressure control, continuous spontaneous ventilation with set point targeting, otherwise known as pressure support or CPAP. Okay, so in this situation, we go to the load. Again, we're looking at the low waveform because we're in pressure support. We're in a pressure control mode. We're not seeing a nice exponential decay. So what does all this represent? PMAS. PMAS, we're getting to see it very well. Everybody says PMAS, very good. So PMAS is our inspiratory load. And because of that, it's difficult to tell what the load is for the patient. Is it elastic or is it resistive? So let's switch over to the expiratory time, which is this phase in here. And we tell what the load is here. What would you guess? This is a little trickier than the last one, maybe. We look at, there is a waveform distortion here, right? So we would expect to see this, and we're not seeing it. So could be resistive, yep. And how you know that? Because what? You have probably a little bit of auto peep. It takes a long time to get to the zero flow. Long time is probably R. Now, but there's something that's sort of making it more difficult to interpret, right? What's this business? What's going on here? See a distortion of the peak expiratory flow. So what that means is the patient's P must started over here somewhere and probably went clear over here. So that not only distorted the peak expiratory flow, clip that off, but it also caused the expiratory flow to be shifted towards positive all during this period. Probably the patient relaxed right about here, and then we get to the normal expiratory exponential curve, which is long. So it could be a high resistance on this patient. So let's say PMUS and possibly R. Okay, so what about the trigger? Is this normal, early, late, or false? First of all, is this a flow trigger or a pressure trigger? Yep, Karsten says normal. Anybody else? We see that this is a flow trigger because the flow waveform is colored white on this ventilator. It's a servo U, I believe. So we're seeing an effort start about here, and we're seeing the start of inspiratory flow here. That's very short. I would not call that a delay with no evidence of early triggering or false triggering. Can't be early triggering because the patient's triggering the breath. So by definition, it can't be early trigger. So let's call this a normal trigger. Okay. So let's move on to inspiration. Would you call this normal level of assistance, over assistance, or under assistance? And the way I generally do this is I imagine what what a passive flow curve would look like, and then look at how much work the patient is doing. So this area here represents how much volume the patient's taking with their PMUS, and this area here is how much the passive patient would get. So this looks to me probably more than 50% of the tidal volume is being delivered by the patient's inspiratory effort. So I would call that probably under assistance, right? Now, we don't have any strong, clear metrics for this in the literature yet, but this is just the way I look at it. It's probably under assistance. So cycle now, let's move on to cycle. Let's say if this was the previous patient, we saw that they had late cycling, so we decided to use pressure support to try to fix that. And what did we get? Did we fix the late cycling if this was the same patient? Did we get into hot water and a different kind of problem with cycling, or is this normal cycling? Normal cycling? Well, if we said P must extends clear over here, then the patient wants to breathe, wants inspiration, clear out all this long. So yeah, it's early cycling, right? So the ventilator says, you have to stop. I'm not giving you any more support at this point. And the patient says, I want support clear out to this point. So this is an early cycle. And since this is in pressure support, what might you want to do? How would you fix this just by fiddling with the settings of the pressure support? What might you do as your first approximation to fix this? Well, first of all, we have to ask the question, what's the goal, right? Before we do an intervention, let's see if we can get a consensus. What's the goal for this patient? They're on 40%. PEEP is still pretty high, but the pressure support's pretty low. What's the goal? Liberation could be. This could be someone doing a spontaneous breathing trial, although the PEEP is too high. Liberation. All right. So if everybody says liberation, you could probably just, if they pass the other criteria of the spontaneous breathing trial, you could just try extubation. But let's say, for the sake of argument, that the patient wasn't clinically ready. They didn't pass an SBT. You wanted to fine-tune this so the patient wasn't doing so much work because of the early cycling. What can you do in pressure support to fix this? What determines cycling in pressure support? The cycle threshold. That's right. You change the percent cycle. Do you go up or down, Karsten? Anybody? If you want to make the average inspiratory time longer, what must you do to the cycle threshold? Remember, the cycle threshold is this. So this is 100%. And right now it might be at 50%. If you want the inspiratory time to be longer, you have to decrease the cycle threshold. So you go down to maybe 10% or 5%. There you go. So I think we have a very thorough analysis of all of this. We're running out of time. So I would say that the key findings here is that work shifting happens both in volume targeted and pressure targeted modes. And work shifting happens in mandatory and spontaneous breaths. It can happen anytime. And so the take-home message here is what you do about it depends on the goal, as always. So if it's safety and you have a large inspiratory effort that you can't fix physiologically, then it may require sedation and paralysis. Because why? Because no mode can handle a large PMUS. You either end up forcing the diaphragm to do work, or you give too big of a tidal volume dosage. Either way, it's not good for the patient. But if your goal is comfort or perhaps liberation, you might be able to optimize the mode settings or even consider extubation, as we have just discussed. So then, in conclusion, these are your, this is your information for getting CMEs if you're a CCF caregiver, and CRCEs if you're an RT. And before we leave, I want to encourage you to send us your waveforms. We're always happy to see them. They give us real-world examples that we can analyze together and improve our ability to recognize patient-ventilator interaction problems. And last but not least, I want to encourage you to consider taking a SEVA course. We have two sets of SEVA courses. One is online self-directed. That's SEVA Basic, SEVA Theory, and SEVA Lab. And we can take the in-person courses, SEVA Method. I think we're offering them twice, at least 2 times a year. And the full SEVA Method OptiVent and Monitor it happens twice a year, once in September and once in April, and we call that the SEVA Summit. So you can get your full SEVA Mastery Certificate if you want to do that. And I look forward to seeing each one of you at one of these things. And so I would say goodbye for today, and thank you for coming.